Namaskar. I am Dr. Puranik, consultant neurologist, ex-professor of neurology, MGM Medical College Indore. Currently, I am director of Puranik Academy of Medical Education. Today, I am going to talk about clinical assessment of coma and altered sensorium. There are some terms and some definitions which need a bit of explanation in the beginning. Number one is consciousness. Everybody thinks that he or she knows what consciousness is, but if specifically asked to define it, one may be at a loss. Yet we will make an attempt to define consciousness. Consciousness is a state in which a person is awake, he is alert, he is attentive, he is oriented, and he is responsive. I will explain these words. So, consciousness is a state of a being who is awake, who is alert, who is attentive, who is oriented. Now, orientation may not be fully, it may be partial orientation, and I will define the orientation word slightly later. And the one who is capable of responding to external and internal environment. For example, if I am conscious right now, of course I am awake, I am alert, I am paying attention to what is happening around me, I am aware of the time, place and person around me, and I am also oriented about the purpose for which I am here at this moment. And I am also capable of responsive. If somebody knocks on the door, or if I have a desire to go to the toilet, so I can respond to external and internal environmental stimuli. That becomes the definition of consciousness. And in neurological examination, patients with abnormal consciousness are very commonly seen, and it is very important for medical students and residents and practicing doctors to properly examine the level of consciousness in a given person. A broad term and a relatively vague term is often used called altered sensorium. It is not a very well defined term, and it includes anything abnormal. Anything other than normal consciousness can be called altered sensorium. Then in the altered sensorium, we can have a person who is drowsy and dull, or who is sleepy, and you require to wake him up again and again and to make him oriented again and again. So that's a dull and drowsy and sleepy person, which is not normal. Another condition is sleep, which is physiological. So sleep is different from normal consciousness, but it is not a pathological condition. And how do we define sleep? So sleep is a state of unawareness. It is a physiological condition. And how is it different from coma? Or how is it different from other pathological conditions? Very simple. A person from sleep can be aroused. And when aroused, he will found himself in a normal condition. So that is the sleep. So we are not going to talk about sleep today. Another term is confusion, and its synonyms are disorientation and delirium. These are the conditions which are of abnormal sensorium, and the person is confused. He is not fully oriented for time, place and person, and I will talk about examination for orientation in another lecture, not in today's lecture, but I am keeping this term here because it is part of altered sensorium. And another technical term for this is delirium. Stupor. Stupor is a condition in between drowsiness and coma. So coma, a person is not arousable. Drowsiness, person is arousable, or he can be made alert for a while at least. Stupor is in between, in which a person appears to be comatose. His eyes are closed, he is not responding, but by vigorous stimulation you can wake him up, and you can wake him up only for a few moments, eyes opened, he may obey one or two command, and he goes back to his slumber again. So that is a condition of stupor, in between drowsiness and coma. And then finally we come to coma. So in coma, the person is not arousable, and there are different grades of coma. Though technically speaking, we should not use the word light coma and deep coma. What words should be used, we will come in a minute. There are two more conditions, number 8 and number 9, which are not part of today's lecture, and they are vegetative state and brain death. So all the conditions above this are part of today's talk, but I will define the number 8 and number 9 condition. In vegetative state, a person looks awake, looks alert, but he is not. So another name is for vegetative state is unresponsive wakefulness. So person looks like wakeful. In fact, he may have a 24-hour cycle of few hours awake and few hours asleep. And even during the wake hours, he is unresponsive. So whatever responsiveness I will tell you in a minute about examination of consciousness, a person in a vegetative state will not be responding properly. And when does it occur? It occurs when any brain pathology which is initially leading to unconsciousness and coma. What can happen to coma? If the condition is very bad, a person may die. If the condition is mild, the person can recover soon within a few days to few weeks, 2 weeks, 3 weeks. But then there comes a middle Trishanku-like stage in which the person neither dies nor recovers. He remains in coma. But if a person is not recovering from coma by around 4th week, by around 1 month, he starts opening eyes and he starts regaining awake state, but still not responsive, not oriented. So he is not conscious. What he has regained only some degree of wakefulness. That condition after 1 month. So coma does not last beyond 1 month. Sometimes we read the stories in newspaper and magazine that a person has been in coma for so many months and so many years. They are not in coma. They are in vegetative state. So persons are not responding, but they look like awake for a few hours out of 24 hours. So we are not talking about that today. And the brain death. We are not talking about brain death also today. Brain death is a totally different condition in which a person has died. So brain death means death. It is as severe and as true a death as a stopping of heart. The only difference is that in brain death, the heart is still beating. And because the heart is beating, the blood circulation is going to many organs, but it is not entering the brain. Brain is not functioning. So we are not talking about brain death today. So now I come to Glasgow Coma Scale. This is the method by which we do the clinical assessment of unconsciousness or coma. A bit of history here. Glasgow is the name of a city. Where is it? It is in Scotland part of United Kingdom. Northern part of UK is Scotland, and it is one of the historical city, Glasgow. And who developed this scale? It was a team of neurosurgeons, the neurosurgery department at the Medical College Hospital of Glasgow, University Medical College. And Peter Teasdale and Janet, these were the two eminent neurosurgeons who developed this scale. And why? As a neurosurgeon. And when? It was in 1973. And why? As a neurosurgeon, they were every day seeing patients of head injury who are brought into coma. They thought everybody is describing the unconsciousness in his or her own way. This patient is comatose, this patient is unconscious, this patient is lightly comatose, this patient is deeply comatose. So whatever you want to mean, you can mean with those words. This is not correct. The clinicians should have a scoring system for coma. And this Glasgow Coma Scale came into being at that time. It's very simple, and every medical student, every resident, and every practicing doctor should learn the Glasgow Coma Scale by heart. There are 3 domains. One is eye opening, number 2 is verbal response, and number 3 is motor response. In these 3 domains, we do the examination of a person for coma. And there are 3 states of assessment. So 3 domains and 3 states of assessment. So for eye opening also there are 3 states of assessment. For verbal response, again 3 states of assessment, and for motor response also. And they are done one after another in a sequence. So the first state of assessment is you simply observe the person in coma. And whatever is happening, you say this is happening spontaneously, I am not doing anything. Observation. The second stage, if nothing is happening, then you try to give verbal command to the patient. You call his name, you can give him some command, that's verbal command. And then even if there is no response, then you give a painful stimulus. The painful stimulus are given usually not in the periphery, not in the limbs, but in the central part. One is the supraorbital pressure. So you press it here and firmly, the supraorbital nerve is passing in the notch and going towards the skin of the forehead frontal bone. Because there is nothing between the skin and the nerve, it's a very painful nerve. On pressing it hard and rolling it like this. Another way of giving the painful stimulus is rubbing your knuckles on the sternum of the patient. This is again only bone and skin, no tissue in between. In case of peripheral stimulus, you can press the knuckles or fingertip like this, either with a pencil or with your thumb, and there can be a painful stimulus. Preferably we should have a supraorbital pressure or external pressure as a painful stimulus. And what do we see? So let us come to eye opening. I said 3 things: eye opening, verbal response, motor response. In eye opening, the scoring range is from 1 to 4. And again, those 3 states of assessment. In the case of spontaneous, only observation, and if eyes are open, the patient gets 4 out of 4 marks. If the eyes are closed, then you give him verbal command. You call the name of the patient, you call him, open your eyes, hey, look here, where are you, how are you doing, something like that. And if on this command, the patient opens the eyes, maybe for a few seconds, maybe for a slightly longer period, then you give him 3 out of 4 marks. And then even if on command he is not opening the eyes, you give the painful stimulus. And if the eyes are opening on painful stimulus, you give him 2 out of 4 marks. And if eyes are not opening even after a deep sustained, and how sustained? About at least 10 seconds. So when you are pressing it here, it should be at least for 10 seconds or on the sternum. And if there is no eye opening, the patient gets 1 out of 4 marks. So that was the scoring for eye opening. Second comes the scoring for verbal response. This means speech and sound output, and the scoring is from 1 to 5. And again, 3 states of assessment. To begin with, spontaneous, you don't do anything, you observe only. And if you find that the patient is talking normally and giving the history properly, of course he is not in coma. And it is a normal, sensible speech, or you are asking him some simple question, what is your name, where do you live, how do you do you know where you are right now? So these type of questions, and if he is correctly telling the answers, he gets 5 out of 5 marks on the verbal response. But if his verbal output is of irrelevant string of sounds, irrelevant string of words or wrong answers, so he is speaking a few words, a half sentence or a full sentence, but that full sentence is meaningless, it is wrong, then he gets 4 out of 5 marks. And even worse than this, he is not speaking any sentence, he is speaking isolated words which are again meaningless and irrelevant. He gets 3 out of 5 marks. And if there are no words, only sounds, the groaning sound, something like that, crying. So if there are only crying or groaning sounds, the patient gets 2 out of 5 marks. And if even on deep painful stimulus there is no sound, then he gets 1 out of 5 marks. And then finally we look at the motor response. Motor response means actions and movements. And the scoring range is 1 to 6. Again, 3 states of assessment. Initially you just observe and see what spontaneous actions are occurring. If nothing is occurring, then you give him verbal command. And if nothing is occurring, then you give him the painful stimulus. If the person obeys command, you ask him touch this, pick this up, and he is doing that correctly, the patient gets 6 out of 6 marks. If he is not doing that, but you are giving a painful stimulus and is localizing. Localizing means if the pain is being given here, the patient brings his hand and removes your hand. So that is known as localizing the painful stimulus. If you are giving a pain here, if you are the patient brings his hand and removes your hand, that is localization of painful stimulus, and that gets 5 out of 6 marks. 4 out of 6 marks will be given if he is not localizing but withdrawing. So if I put a pain here, patient turns his head and neck away. If I am putting pain here, he brings his hand away. So he gets 4 out of 6 marks. Even worse than that, you give a painful stimulus here and he just makes his upper limbs flexed like this. The lower limbs may either be extended or flexed, and this type of posture is known as decorticate posture. So he gets 3 out of 6 marks. And even worse that patients who are in a still deeper coma will have still poorer response, and in those patients when you give a painful stimulus on the sternum or supraorbital pressure, they would extend their limbs. So as soon as you give the painful stimulus, the upper limbs would be extended and internally rotated, and so the lower limb, and that type of posture is known as decerebrate posture, and the patient gets 2 out of 6 marks. And the deepest coma is the one in which even after a very severe painful stimulus, at least for 10 seconds, there is no response, no action, no movement. The patient gets 1 out of 6 marks. So now you can imagine the Glasgow coma scale will have a minimum of 3 out of 15. So in each case, there was one number for the worst response, and the maximum would be 15 out of 15. You can imagine a person who is scoring 15 is fully conscious and he is fairly well oriented. However, if you go into a more detailed assessment of orientation, there may be some errors, but he is fully conscious. If the score is between 10 to 14, and how do you get this score? By adding up all the 3. As I told you in the very beginning, that for eye opening there are 4 number, and for verbal response there are 5, and for motor response there are 6. That makes a total of 15. So if the patient's score is around 10 to 14, he may be drowsy and disoriented. If the score is between 6 to 9, the patient is in a stupor or light coma, though we don't use the word light coma. And if the score is 3 to 5, he is in a deep coma. This is often the case. If a patient has come in the middle of the night in my ward and I am the consultant and my resident is making a phone call to me, sir, a 20-year-old female has come with 3-day history of fever and she is in altered sensorium or she is unconscious. And before I ask him the question, the resident is very intelligent and smart. He says, sir, her Glasgow coma scale is 3/5. Now understand everything. I need not ask him whether she is opening the eyes, whether she is speaking. If the resident says, sir, the coma scale is 3 out of 15, or then if he says, sir, the score is 9/15, then and the intelligent RMO without asking me will tell, sir, this 9 score has come because she is having eye opening on verbal command, and her verbal response is isolated words which are meaningless, and her motor response is flexion, so the total comes to be 9 out of 15. So this is how we the doctors, we the medical students should communicate amongst each other. See, if I am talking about a patient seen by me and the patient is not here, and you are my friend and you are listening to my story, or you are my teacher and I am presenting my case and I want to tell you the patient which I examined was unconscious and this was his level of consciousness. So I should talk in a uniform language which is understood by the medical profession all over the world. Hence it is important that all doctors and all medical students learn the Glasgow coma scale by heart. And finally, there is another assessment score for coma. This is known as 4. The 4 is an acronym, full outline of unresponsiveness. This has become slightly popular, not as popular as Glasgow coma scale, but it has become somewhat popular because of some advantages in last 10 or 15 years. It has yet not found much place in our textbooks, and your examiner may not be knowing much about it. So if you know everything about Glasgow Coma scale and you are interested in learning more and it is really a good scale, you do learn and you can talk about it to your teachers. So what is the 4 score? Full outline of unresponsiveness. This is a busy slide, and I will say that in this the first column, that is eye response, is more or less same as Glasgow Coma scale. So there are some differences, but I'm not talking about those differences. The motor response is more or less same as Glasgow Coma scale. There are some differences, but I'm not talking about that. But what is more important, what are the differences? The differences are in the brainstem reflexes. This was not part of the Glasgow Coma scale. Brainstem reflexes. And what do they, and there is a scoring. So the scoring is here from 0 to 4. It is slightly different from Glasgow Coma scale. And in the brainstem reflexes, one should look at the pupil and corneal reflex. And if they are both present, the patient gets 4 marks. If one side is absent, patient gets 3 marks. If they are absent on both sides, the patient gets 2 marks. And if they are absent along with some other finding, the patient gets 1 mark. And not only absent pupil and corneal, but if cuff reflex is also absent, then the patient gets 0 mark. So this is how they do the scoring for brainstem reflex. And then another thing which has been included in the 4 score is this respiration. So they give scoring for respiration. If respiration is fully normal, no intubation, 4 marks. And if the patient is on ventilator, he gets a 0 mark. So eye-opening response, motor response, somewhat similar to Glasgow Coma scale, but different scoring. No marks for verbal command in this case, verbal response. But then they have included 2 things, the brainstem reflex, which includes pupil, corneal, and cuff reflex. And then respiration, whether the respiration is without ventilator, with ventilator, and a few more points in between. So that's how you make a maximum score of 16 and a minimum score of 0. And so with that, I come to the conclusion. And these are some of the homeworks for students. You must memorize the Glasgow Coma scale by heart, but that is not enough. You should practice Glasgow Coma scale on patients in ICUs and wards. So please go to the wards. The patients who are in coma and their attendants will feel hurt if you directly start examining without taking their permission. You have to take the permission. If the permission is not being given, you request the resident or doctor on duty in the ward, sir, I want to examine, please tell me how to examine a patient of coma or unconsciousness. They will teach you. So you should do this practice. Then another homework for more ambitious students, they should memorize the 4 score also and practice the 4 score again in ICU and wards. Not very difficult. You have to examine the pupillary reflex, the corneal reflex, and the cuff reflex. I am not teaching how to examine those reflexes in today's lecture. For that there would be another lecture. And then you should look at the respiration with ventilator, without ventilator, and a few more points in between. So memorize the 4 score, practice the 4 score in ICUs and wards, and here is final homework for good students and good residents. Make a comparative table of Glasgow Coma scale and 4 score for some patients. Patient 1, patient 2, patient 3, patient 4, patient 5, Glasgow Coma scale and 4 score. Make a comparative table. And then think which scoring system is better. So with that, this lecture is concluded. Thank you very much for your attention. Bye.